In this video, we'll discuss about heart failure drugs. Before understanding the drugs, the mechanism, we must understand that disease. So first we want to understand what is heart failure. See the diagram of heart. This is left ventricle. So here left ventricle. In heart failure, the left ventricle is not pumping properly. Left heart failure, we are talking the left ventricle is not pumping normally. The left ventricles pump the blood, goes into this aorta, the pure blood, oxygenated blood, and aorta distributed it throughout the body, throughout that body in all the organs. But now the left heart failure, the left ventricle is not pumping properly, so blood is not received by all organ. Blood is not received by all the organ, so that is heart failure. We have backup. The backup, there is sympathetic stimulation. We have backup sympathetic stimulation. Heart feel is an emergency. Blood is not going in aorta and all the organ are receiving less blood or no blood. Here less blood or no blood. All organ, it's an emergency. In emergency, sympathetic stimulation occur in the body. So inside the heart, in that left ventricular wall, there is a cell, the black color one. There is a cells. These are known as cardiomyocytes. Cell name is called cardiomyocytes. On them, in the cell, beta 2 receptor is present. This one is the black color one is the cell. Here it having beta 2 receptor. Whenever there is sympathetic stimulation, adrenaline, that noradrenaline, noradrenaline will come in the blood. So whenever the heart is not pumping, the left ventricle is not pumping, all the organ not receiving blood, it is an emergency. The body will secrete the adrenaline. It is a sympathetic stimulation. This one is the sympathetic stimulation. So they that will go on heart. This receptor, cardiac stimulation, beta 1 receptor, they will increase that rate, that force and conduction, that velocity. So the beta 1 receptor are present and that will increase that contract. So whenever the heart is not pumping, automatically that sympathetic stimulation will take place. Noradrenaline will come in the blood and that noradrenaline will act on beta 1 receptor presented on the wall of that left ventricles and it increases that contractility. So it will increases the contractility. So the heart failing heart which was not contracting, it start contracting again for the next few hours or maybe days. This one name is called as compensation. Muscles in the weak, sometimes MI, myocardiopathy or cardiotamponent, whatever there is a disease, but here temporarily the heart again started bumping because of beta 1 adrenergic receptor. it is presented in that wall of that cells. Okay, again start pumping because of that process name is called as compensation. Because of compensation, one good things, two bad things will occur. Okay, because of compensation, one good thing, two bad things, two harmful effect of this compensation. Beta 1 stimulation is good. Okay, in the heart started to pumping, but this noradrenaline is presented in blood. It will go to two more places. It will go to that heart, it is doing good here, but it will go to two more places. The same noradrenaline here, it increasing that contractility, but it will go into that kidney, uh, and it will increases that secretion of renin from that kidney. So what does that renin will do? Renin angiotensinogen pathway will come in this role. So that renin angiotensin pathway will increase that blood pressure. So overload, okay, it is the overload. It increases preload and it will increase afterload. So in a failing heart, it will do sodium water retention. Renin will do sodium water retentions, will increase that blood pressure. So it is bad things because heart is already failing, it will increasing that workload on heart. This is not good thing for heart. So what are the two bad things? Adrenaline will secrete. Okay, so this renin aldosterone increasing sodium water retention, it is overload for our heart. Normally it cannot pumping 5 liter, now 6 and 7 liter. So it increasing that heart failure. Vasoconstriction also workload. So this one inotropic effect, inotropic effect is good for our health. This over that adrenal secretion and vasoconstriction workload is heavy for our heart, it increasing heart failure. So what is good? Good things, it increasing that contractility, that is good. We want that because heart is failing, we want to increase that contractility via beta 1 receptor presented on the heart. On the left ventricle cardiomyocytes, we want that, but two bad things are happening. So beta 1 receptor on the kidney got stimulated and it will secreted renin. That renin will secreted that aldosterone. From that adrenaline, it will causes sodium water retention. Because that sodium water retention, it increases workload on the heart. So it will increases workload on the failing heart. And the second things, the uh, blood vessels second things on blood vessels, the alpha receptor also gets stimulated. Alpha receptor will causes vasoconstriction of the arteries as well as vein. It will increases the preload afterload. Again the workload on the heart will increases, since the workload on a failing heart will increase. The left ventricular hypertrophy will occur. So left ventricular hypertrophy will occur. The muscle will increases the thickness as the adaptation. In pathology, hypertrophy, hyperplasia, atrophy, metaplasia, dysplasia we studied. So left ventricle wall will become thicken to compensate, and that not good thing. That is the most important cause of morbidity and mortality in heart failure, conjunctive heart failure. that is left ventricular hypertrophy. So what is the summary? When left heart failure, left ventricle is not pumping. Now imagine a person whose left ventricle is not pumping, so blood is not coming this aorta. Okay, in the aorta all the organ are not receiving the blood, they are receiving less blood or no blood. Because left ventricle is not pumping, it is an emergency, so sympathetic stimulation will takes place. Sympathetic stimulation will takes place, it is an emergency condition. Noradrenaline will come in the blood quickly within a fraction of second. Noradrenaline will go on three organ. Noradrenaline, it will come only the heart. Okay, only on the heart. You can see the left ventricular valve having cells. These are known as cardiomyocytes. Cardiomyocytes, we have beta 1 receptor are present in it will increases that contractility, and failing heart which is was not pumping, it started contracting again, it is good. Okay, so second, noradrenaline is doing good things here. First thing, good things, this noradrenaline will do here that contractility. Second things, apart from heart, it will go to it will do some harmful effect. So this noradrenaline which is coming into blood as a sympathetic stimulation in emergency. So in heart it will do contractility, that is good. This one name is called as inotropic effect, that can sustain that falling heart from little longer, but over that adrenal and that over the blood vessels it is doing harmful effect. Same noradrenaline, over that adrenal it is secreting renin, so renin will secreted aldosterone. Aldosterone will causes sodium water retention. Sodium water retention in the body means it will increasing overload of that heart. It will causes vasoconstriction. So vasoconstriction means again it will increases overload on that heart. So heart failing, left ventricle is unable to pump. There is 5 liter of blood in our body, 5 liter of blood. The 5 liter of blood heart is unable to pump because left ventricle is weak, it cannot pump, but you are increasing 6 to 7. This renin also, that vasoconstriction also will increase 6 to 7 liter, so it is not able to pump 5 liter, it is increasing that workload here, so it is doing sodium water retention and increasing workload of that failing heart, so it will increases the heart failure. So one good things, two bad things here. So drugs for heart failure, contractility is increased only for little longer. The heart contractility is increased because of noradrenaline beta 1 stimulation. We can give inotropic drugs. Inotropic drugs will increase the contractility of heart till we give that inotropic drugs, that contractility will be more. So here that one is the first drugs. First drugs is inotropic. Remaining all the drugs. So remaining all the drugs, two harmful effect. We know that compensation of heart failure, one things is good, two things is bad. For that reason only we are using these drugs. Remaining all the drugs are oppose that compensation which is harmful to uh, harmful compensation. So alpha stimulation is causing the vasoconstriction. um, Now we give alpha blocker. Okay, so we will give alpha blocker. um, so alpha stimulation is causing that vasoconstriction. Now we will give alpha blocker. And beta stimulation, okay, beta stimulation is causing by renin secretion. So we will give beta blocker. So we give alpha and beta blockers. Then arteries are contracting, we give arterial vasodilator. Vein are contracting, we want to give vein. So both arteriolar vasodilator and that venous vasodilator both show, okay, we are using. So we want to give both dilator. Then renin increased, we don't want to increase it, so we give ACE inhibitor and ARB, yes, inhibitor. Okay, they inhibit renin, so we will give ACE and ARB, that is the drugs which oppose that RAS. Then aldosterone is increased, we will give aldosterone antagonist. We give that this one is the diuretic antagonist. Then sodium water retention, we can give diuretics because heart is not able to pump 5, or here blood is 6 to 7 liter. So we want to excrete that extra fluid, so we want to give that diuretics. So now easily understand that classification. So decrease cardiac contractility, that compensatory mechanism, increasing sympathetic activity. So alpha stimulation, we give alpha blocker. Vasoconstriction, we will whether it may be artery or vein. Artery means arterial vasodilator, venous means vein means venous vasodilator. Beta stimulation, we want to block by using beta blocker. Increasing renin, we will give ACE or ARB inhibitor. Then aldosterone and aldosterone antagonist. Then water sodium retention, we want to give diuretic because our heart cannot pump 5 liter only, but here it will increase 6 to 7, so we want to remove extra fluids. So these are the drugs. So increasing overload of that heart, that cardiac remodeling, here hypertrophy will occur, increasing mortality of chronic heart failure. So how many drugs we give to treat heart failure? Now no need to understand that mechanism of action in each and every drugs. Okay, so here inotropic drugs we give to increase that contractility. Then we give alpha blockers, so that alpha receptor on that blood vessels are blocked. Alpha blockers. Then we will give adrenal dilator, venodilator, or both dilator. Okay, then dilator, this one. Then we will give beta blocker to block beta 1 receptor on kidney to inhibit renin secretion. Then we will give ARS inhibitor to inhibit renin and ARB. Yes, we give aldosterone antagonist to inhibit that aldosterone. We give diuretic because it is sodium water retention. So these are all classification. Most important one is this one, inotropic drugs. So inotropic drugs are three types. What are the three types? One is cardiac glycosides, then sympathomimetics, then phosphodiesterase enzyme 3. These are the three drugs. One is cardiac glycosides, second one is sympathomimetics, then phosphodiesterase enzyme 3. We want to discuss these drugs, mechanism of action. Cardioglycosidic drugs, we are giving two drugs. One is tijacin, another one is digitacin. Digitacin together is known as digitalis. Okay, together name is called as digitalis. Digitally means both. That means tijacin and digitacin. So this is different in their pharmacokinetics, but there are together known as digitalis. Now we want to see that mechanism of action. Both mechanism of action is similar only. Most important inotropic drugs, cardiac glycosides, digitalis, tijacin or digitacin, everything is same. So it increases that contractility. How does normal heart do the systole and diastole? What is systole means contract, diastole means relax. So what is the inotropic drugs? Okay, it will increase the contractility, so it increase systole, not diastole. So it increasing contractility. Okay, so increasing systole, not diastole. So we want to understand that mechanism of action of inotropic drugs. We should understand how does the normal systole and diastole, okay, that one. If we want understand that physiology, we can easily understand that pharmacology. How does systole and diastole normally takes place? Okay, left ventricle, here it having cells. Okay, these cells, this one only zooming version, this one. Okay, so this is the cell membrane. Okay, the cells presented on the heart. This one is the wall of that left ventricle. Okay, wall of left ventricle. How does this systole takes place in the cell membrane? So this one is the cell membrane. On the cell membrane we have various transporter. Okay, we have various transporter. First transporter is calcium channel. This one is the calcium channel. Okay, this one outside, very little bit calcium, 1%. Okay, very little bit calcium enter inside. Okay, enter at that time systole, here 1% calcium only enter, and it is going to cytoplasm. Okay, it will go to endoplasmic reticulum of that cell. So now it will reach to cytoplasm. After that it will enter to endoplasmic reticulum or sarcoplasmic reticulum of the cell, on which another receptor. Okay, so by using receptor only it will go inside. Name is called radiant calcium receptor, channel. Okay, so RYR2, with the help of this RYR2 only, radiant calcium channel only, it will enter. So here abundant amount of calcium is presented. So it will stimulate that receptor. One things, okay, this stimulate, and inside here abundant of calcium is present. So all the calcium also will come out. So all the calcium will come out. Already 1% from here, 99%, now 100% calcium in cytoplasm. Okay, 1 from outside, 99 from endoplasmic reticulum. First 1% come from outside, from the calcium channel cytoplasm of the cell. Here 0 calcium. Okay, so first 1% of calcium from outside, that 1% triggering that receptor, that 1% only triggering that receptor. Okay, that Reynolds receptor presented on that endoplasmic reticulum. Once that Reynolds receptor gets stimulated, the remaining 99 calcium will come out, totally 100%. Now it is presented. It will occur in cytoplasm. So in the cytoplasm, suddenly calcium transiently increased too much. So this increased calcium will causes actin myosin, this one. Okay, contractility. So actin myosin filament here, so it will increasing that contractility. It will bind with the troponin and it will causes actin myosin contractility, and the cell will contract. This is systole. Now that cell will contract. This is systole. This is how systole takes place. Now systole is done here. Okay, how does diastole takes place after that? So after the systole over, once the systole is done for that particular period, there is a systole. After that, what will happen? On endoplasmic reticulum, one receptor was, okay, here one more receptor. So one receptor was RYR2 receptor. From calcium was coming 99%. There is one receptor. One more receptor is known as SERCA2. SERCA2. Okay, full form of SERCA, sarcoplasmic endoplasmic reticular calcium ATPase2 receptor. Okay, will get activated. It will take calcium again back. Okay, it will take calcium again back. Whatever given is taken here, taken back. Whatever fraction is given, so 99 is given, so 99 is taken back. So whatever given by this RYR is taken by this SERCA2. So only 1% calcium here, only 1%. This 1% are left here. Okay, which was coming through voltage calcium. Now 1% calcium want to go outside. Okay, that 1% calcium want to go to outside. So it will go to a transporter. Okay, this one is the transport presented on the cell membrane. This transporter is name is called as sodium chloride calcium sodium calcium exchanger, NCX. Sodium calcium exchanger. It will request that this transporter. So this transporter say okay, it will go, this calcium will go outside. So after that, inside of that one, it will take sodium inside. So calcium will go to outside, that sodium will come inside, because SCX, this one sodium calcium, this sodium calcium, this receptor exchanger. Okay, here this one is the sodium calcium exchanger. So it will send calcium outside, sodium inside. So this exchanger, this one will tell you go outside, I will take that sodium. So sodium will come inside. So sodium now reach inside. What happened to that sodium? Once that sodium come inside, there is one more transporter. Okay, here one more transporter is there. That sodium potassium ATPase. sodium will go to outside. So through this channel it will go to outside, and potassium will come inside. Okay, so that the diastole is done. So what will happen? Sodium will go to outside and potassium will come inside. So the diastole is done. This is how diastole occur. So this is how systole and diastole occur. So normal systole and diastole we understood. What is the mechanism of action of digitalis, that drugs? Okay, so a little bit of calcium 1% come inside, then this channel will activated through this RYR2 channel. It will reach to inside. Here 99% calcium is coming outside. Now totally 100%, that is causing that troponin activation, the actin myosin activation, that is causing that troponin C activation. Then that is causing actin myosin contraction. So here contract systole occur. Here heart contract systole. After that systole get stimulated, this SERGA2 presented in sarcoplasmic reticulum, and it will take back that calcium whatever given by RYR. It is taken by this SERCA2. The 99% is gone. Now only 1% which is bending, it is going with the help of sodium calcium exchanger. Okay, it is doing, it takes place that calcium out and that taking sodium and calcium out and sodium in. Sodium is going via sodium potassium ATPase. Okay, so this one is the normal. Now what is the mechanism of action of digitalis? The drugs block this sodium potassium ATPase. The drugs will block here. So what happened? So if that sodium potassium ATPase receptor is gone, how that systolic increased? Same cycle. So 1% of calcium come inside, it is going to RYR2. From RYR it is tracking, remaining 99 is coming. So calcium is causing contraction, systole is done. Now it is the time to diastole. Whenever given by RYR, taken back by SERCA2. Now 1% is left. Okay, 99% reached here, 1% is left. Normally this 1% is going to NCX, then sodium will come inside. This sodium through Na sodium potassium ATPase channel, it will go to outside, then potassium will come inside. But here it will block, this drugs block this sodium potassium ATPase this transporter. So now this 1% of calcium presented inside here only in the cytoplasm of the cell. Now this 1% calcium will go again with the help of PYR. It will go to inside. Okay, so it will go to inside. Again it causing systole. 1% will be trapped inside the cell only, so that will again go to RYR receptor, again causes systole. So systole is exaggerated, intense, prolonged. So systole is exaggerated, intense, prolonged, and this is the mechanism of inotropic drugs. So mechanism of action of digitalis. Digitalis is black sodium potassium ATPase transporter, that is it on that cardiac myocytes in that left ventricle. It black, that if is black, that now sodium will not go out, so intracellular sodium will rise. So when 1% of calcium will request to the sodium calcium exchanger can go outside, this exchanger will reject this offer, so 1% will trap inside the cell only. Again and again it will stimulate that sarcoplasmic reticulum. Again and again it causes contraction, it increases that contraction, and it is the inotropic drugs effect. This is how that digitalis is affect. How that digitalis will enter now. How does the digitalis the drugs enter now? There is a problem. Okay, so this is the digitalis is black. Okay, they're blocked. This receptor from that inside, it cannot block from outside. So that is see here. Inside only, this one block inside only, not outside. Okay, it cannot block outside, so it has to enter the cell. Under it can block from the inner surface, it can block, it cannot block that outer surface. So to come inside and compete with the potassium. Okay, so it will compete with this potassium, and digitalis both are coming, both want to come inside. So if that potassium is less, both, and whose concentration is more, that will come. If potassium is more, if potassium is less, digitalis is come more inside. If it will contract the heart more, and it can causes arrhythmia of the heart. So digitalis toxicity can occur in hypokalemia. So potassium decreases, increases chances of toxicity. So increases calcium, also increasing the chances of toxicity. So calcium and digitalis both are causing contractility, so it will increases that contractility. So decrease potassium and increase calcium both are increases chances of digitalis toxicity, because digitalis is a drugs which is having very narrow therapeutic index. Okay, very narrow therapeutic index. So what are the two causes? Decrease potassium and increase calcium, both are causing toxicity. Next, uses conjunctive heart failure to increase inotropic effect in arrhythmias and decreasing heart rate. So increase inotropic effect and in arrhythmias and decrease heart rate. Heart failure drugs. One good things, two bad thing. Inotropic effect, good thing. Thanks for watching.